Thanks for the time
صوت
I try to think to a topic that will link the mitral valve to the aortic valve. And I couldn't find better than the intervalvular fibrosa or the fibrous skeleton of the heart because it's intrinsically the anatomic link between two valves. I have no disclosures for that talk, but I'm going to go straight ahead and present a case that will exactly give that message. So this patient was a 64 years old female patient. She had multiple comorbidities, so high risk patient. She had multiple stents, peripheral vascular disease, chronic lung disease. She has peripheral previous strokes with seizure disorder, as well as chronic atrial fibrillation. She was initially diagnosed with severe aortic stenosis, and she was basically advised to have a TAVR procedure. And because, as we see, she has severe peripheral vascular disease, so the access to the TAVR was through direct aortic Sabian valve through an upper mini sternotomy because of her multiple comorbidities. And this was done almost a year before she presented to us. She came in a New York Heart Association class 3. Basically, she never really got any symptomatic improvement after her TAVR procedure. And when we repeated the imaging, including TE, as you can see, there is significant degree of mitral and annular calcification, severe inflow obstruction, and a mean gradient at least 10 millimeter mercury across the mitral valve at rest. Her TAVR was working fine, maybe some mild paravalvular leak, not surprising, and a good left ventricular systolic function. When I studied the hemodynamics and we did a right heart cath, the patient has all the stigmata of mitral stenosis, as you all know, severe pulmonary hypertension, and her wedge was 40. So because we know there is no percutaneous interventions and for this, and also we know the futility of medical therapy with a high mortality, even at 1 year for patients with severe mitral stenosis and pulmonary hypertension. So we offered her a reoperation, basically to address primarily her mitral valve. But when you look at that echo, you can see it's a circumferential degree of MAC with calcification of the aortomitral curtain. So we did not expect to have an easy mitral valve, isolated mitral valve replacement for that case. Just to shed some light of the aortomitral curtain or the intervalvular fibrosa, and basically a reconstruction technique for that complex anatomical problem, which is basically described by many surgeons. Dr. David presented a series of this in the AATS 1997. And it's well known as a commando procedure. However, the proper term is basically reconstruction of the aortomitral curtain or the intervalvular fibrosa. This is just to simplify the video that I'm going to show you shortly. Basically, you do an aortotomy, and you do an oblique aortotomy, you extend it down to the non-coronary sinus, and you cut across the aortomitral curtain into the left atrial dome. So at the end, you have almost all the aorta, left ventricle, and left atrium as one chamber, and communication between the aortic root and the mitral annulus. And you can imagine from this approach, we can definitely enlarge the mitral annulus by at least a third of the circumference. At the same time, you can enlarge the aortic root. So it will be a great procedure to address any patient prosthesis mismatch or patients who has destruction of the curtain due to whatever pathology, as I'm going to summarize at the end. So we'll go to the video. So here we did the re-op sternotomy. We dissected the dome of the left atrium, and we did an oblique, very generous aortotomy that will go basically vertically toward the TAVR valve, which was taken very easily, inoculated out of the left ventricular outflow without any issues. We resected the aortic valve and did debridement of the aortic root. We took out all the calcified leaflet. Then now we cut across the aortic annulus, the non-coronary sinus, toward the dome of the left atrium. We enlarged the left atriotomy toward the right superior vena cava. Some surgeons actually disconnect the SVC, but not necessarily needed in all cases. We then expose the anterior mitral leaflet, and then we transect the anterior mitral leaflet, which was heavily calcified in the middle of the leaflet. So that will give us good access to the subvalvular apparatus. We took all this hypertrophic papillary muscle. We basically amputated the muscle from the left ventricle because we needed to enlarge the left ventricular cavity. Those patients has usually small left ventricular cavity. So we took out most of the subvalvular apparatus, leaving only some few connections to the posterior annulus just to prevent AV groove disruption. We then resected the anterior mitral leaflet, leaving only 2 millimeters of the annulus, and that gave us perfect exposure to the posterior mag bar. This patient had a lot of calcification. So we did debridement of the calcium from the posterior annulus. You don't need to get too aggressive, so you avoid AV groove dissociation. And this patient, because she had atrial fibrillation and high risk for stroke, basically we did a cryomaze ablation through the dome of the left atrium. We had a fantastic exposure here. As you can tell, the whole middle of the heart is open. We sized the mitral valve, and you can definitely oversize the valve. This was a 31 magna pericardial valve, which we thought would be a good size. We then started to put mitral valve replacement suture. We started the lateral trigone of the heart, and then we will put the medial trigonal sutures. We start by this suture because it also acts as a retraction suture, so you don't have to add specifically retraction suture to expose the posterior mitral annulus. We then close the left atrial appendage from inside, and we tie the suture outside the heart over a pledgeted suture. This is easy because we didn't want to dissect the lateral wall of the heart to clip the appendage. We then proceeded with the mitral valve replacement. Here you see we left some of the calcium. You have to use big needle, big SH needle, and basically bounce behind the shoulder of the calcium bar. Not too deep at the P1, P2 area, because you don't want to basically get the circumflex in the suture line, and also to avoid deep muscular suture, which can be an idiot for AV groove disruption. The mitral valve is lowered into position, and then the sutures are tied. We then reconstruct the curtain by measuring the intertrigonal distance. You add few millimeters on both sides to compensate for the suture line. And that will be our new trigone. It's usually an oval-shaped batch. The posterior part of it will be used to reconstruct the dome of the left atrium, and the rest will be taken out to the aortic root. The batch is folded, and then it lower down. We start by suturing the lateral trigonal suture first. This is a very crucial step of that operation, because if you have any bleeding from the lateral trigonal of the heart, this is almost impossible to see after you take off the cross clamp. So we pay a lot of attention to that first suture, and we almost start all the cases by suturing that corner first. The batch is lowered into position, and then we reconstruct the dome of the left atrium by running 3O proline suture using SH needles backward. And then we reconstruct the curtain by suturing the anterior 1/3 of the cuff of the mitral prosthesis to the full thickness pipes through the batch. And that will be our new curtain, basically. We go from the lateral commissure to the posterior commissure, and then the sutures are tied. We'll leave a vent through the dome of the left atrium at this point, and then we'll pay our attention to the aortic root. So now we're done with the mitral valve replacement and reconstruction of the dome of the atrium. Now it became sort of a root enlargement. The batch is taken out up to the edges of the aortotomy, and we have a very vacuolous big aortic root. That valve was sized, I guess the original size before we did the enlargement was 23. Now we can implant a 27 magna valve. Remember, at the non-coronary cusp, the suture has to go through the patch. You can put the pledget inside or outside, doesn't matter technically. The valve, the aortic valve, is lowered into position again. Sutures are cut, tight, and then we have to confirm patency of both coronary arteries. After you implant the aortic valve, like any routine aortic valve replacement. Here we needed another small triangular batch just to make sure we close the rest of the aortotomy under no tension. But that part can be basically closed directly according to the situation. So as you can tell, this patient had, from the echo, a very well-seated mitral prosthesis. There was no rocking motion, no paravalvular leak, no gradient. Very good result. Very wide open outflow tract and well-functioning aortic valve. So we thought that that was a perfect anatomical correction for a very complicated problem. So just quickly to shed some light on the interventricular fibrosis reconstruction. So we know that this is a versatile procedure. It has a lot of indications, basically. And if you have any case where there is destruction of the fibrous trigone of the heart or the intervalvular fibrosa due to endocarditis, specifically prosthetic valve endocarditis, or calcification like mitral annular calcification, as I showed in this case. Also, multiple redos. We know we do a lot of redos, and many times you can see that you run out actually of the fibrous trigone of the heart and you don't have annulus to suture to. So that technique can be useful in that perspective. And as we know, by definition, this is a simultaneous enlargement of the mitral and the aortic annulus. So you can do it to prevent or treat patient prosthesis mismatch. As we know, we do a lot of double valve replacement in Egypt for rheumatic heart disease, and those patients they tend to have a small contracted aortic and mitral annulus. So that can be an alternative for these cases. However, I should say that this is a definitely technically challenging procedure with a long learning curve. It definitely has a long bypass run and long cross clamp. This case, I looked at the surgical note yesterday. The cross clamp was 4 hours. Bypass took 5 hours to do that whole surgery that I summarized in a 5-minute video. So we have to pay a lot of attention to myocardial protection. We use retrograde, almost continuous retrograde cardioablation in these cases, and specifically we measure the septal temperature to make sure the heart is cooled down during the procedure. We aim for a septal temperature of less than 15 Celsius. Again, bleeding risk big time, especially from this lateral trigonal area. Caprol patch can be used, not uncommon in this situation if you cannot see where is exactly the bleeder. We avoid using glues in general because it can have a problem with the patch on the long term. We believe that it can lead to fistulas or communication, so we refrain from using any glues or adhesives during the procedure. Again, re-operations after commando are very complex operations, and sometimes the anatomy is even impossible to understand. So it's debate whether to use mechanical or tissue valves. So I'll leave that to discussion. And at the end, I should always consider less complex procedure whenever feasible. So this is definitely not our first choice for these cases.